To all of you. It's my pleasure to be in here. I think over the next 15 odd minutes, I'll try to briefly summarize precision medicine. I've oversimplified precision medicine to make it simplified, and of course, I've left out the details, so please pardon with me. Now, when we talk about precision medicine, then that would also mean that there should be something called imprecise medicine, or that would give the notation that the present medicine is imprecise. And in fact, that is very well documented. And in fact, this is a publication way back in 2004, which sort of quantifies the treatment efficacy across specialties. And you would see that the treatment efficacy could be as low as 75% or as high as a third, around 38% in some specialties. Now, why is this so? This is largely because of two factors. And the first factor is, of course, the mechanisms or the molecular mechanisms of many of the diseases are very different depending upon the genetic background. And the second, of course, while we did make the molecular diagnosis, the treatment still is across the spectrum, and therefore there are genetic variations which could affect the treatment in terms of the metabolism or the drug action. In other words, one of the components or the major components today that affects both of them is essentially the genetic variability. Now, when we talk about genetic variability, we need to understand that there are different kinds of genetic variants. They could be rare or they could be common, and they could all have different effect sizes. That would necessarily mean that on one end of the spectrum, you could have genetic variants, like for example, sickle cell variant or a thalassemia variant. If you have a homozygous sickle cell or thalassemia variant, you are pretty much sure that the individual will manifest the phenotype. And that's, otherwise, the effect size on roughly the odds ratio of a variant having been associated with the disease. But on the other end of the spectrum, you have common variants and common disorders like diabetes or cardiovascular diseases for that matter. These are not primarily genetic, they're largely because of lifestyle, but nevertheless could be contributed by the genetic component. And if you put genetic variants and diseases in the spectrum, you would find a variety of genetic diseases. The rare diseases on one extreme, what we call as Mendelian genetic disorders. Then there are, of course, oligogenic genetic variants, common diseases with rare genetic variants. I'll delve deeper into it. And of course, you have common diseases and common variants. For the matter of time, let's keep it aside because it's not of clinical utility. The other end of the spectrum is when, for example, you have taken a drug, or if you prescribed a drug to the patient typically takes a drug as an oral route just to refresh a bit of pharmacology. It is metabolized by the liver, called the first-pass metabolism, distributed in the systemic circulation. And then, of course, in the systemic circulation, it extravasates to the extracellular space, and that's exactly where the cells reside. And then it has to cross into the cell or on the surface of the cell to act upon. And of course, there are two more organs which metabolizes, of course, the kidneys, which metabolizes them into soluble form in the urine, and therefore it's excreted. So in other words, when you give a drug to an individual, it needs to be transported across multiple different membranes by either active or passive transport. The active transport is because of carrier proteins. Then it's metabolized and excreted by another set of metabolizing enzymes, and then it's available for the interaction across the gene or the drug target. And each of them are essentially encoded by the genome, and genetic variations in each components could differ how a drug acts on a human body. So this is an area which is called as pharmacogenomics. So put together, these two essentially contribute to the variability in diagnosis as well as the clinical actionability. Now, for lack of time, I will just focus upon two specialties, not because I love those specialties, just because though there are guidelines in those specialties, they are rarely being used. And one of it, of course, very relevant to Kerala is chronic kidney disease. While we tend to club chronic kidney disease into one single box, which says that, of course, there are many different environmental etiologies or for that matter, genetic etiologies, we typically tend to club them together and, of course, offer them a very common treatment and a prognosis. In a very recent publication which came in NEJM, what they did was to essentially do genetic studies across a large spectrum of chronic kidney diseases. And what they found was even more remarkable, that approximately 9% of individuals did have a Mendelian genetic disease. And this Mendelian genetic disease would offer them a diagnosis, a perfect diagnosis, and of course, each of them would have very different prognosis. And more importantly, it can aid in the management plan to the individual. And following this increasing evidence, today the National Kidney Foundation has a very elaborate guideline on who should be tested in chronic kidney disease. And to put numbers, this new guideline approximately today encompasses almost 30 to 50% of all patients with chronic kidney disease who will now become eligible for a genetic testing. And a genetic testing would offer them a diagnosis and, more importantly, a perfect, precise management plan. Now, put numbers, approximately 9% of kidney transplant recipients do have a genetic disease, and they would benefit from genetic counseling approaches. The second specialty I would like to talk about is cardiovascular diseases, and for that matter, in that very specific area of heart failure, where today there is very increasingly important insights on how genetic variants could modulate the disease, and of course, could offer prognostication, more importantly, very recently with new therapies available, how they can be precisely managed. And even for heart failure today, there are guidelines available largely encompassing cardiomyopathies. The 2021 and 2022 guidelines have sort of arrived at a consensus that people with non-ischemic cardiomyopathy and their first-degree relatives should be offered genetic testing. In fact, there are some centers, including the Mayo Clinic, where they have an opt-out system that necessarily means that every individual who comes with heart failure would get a genetic testing, and of course, the clinician can opt out of the genetic testing if it need be. Now, when we talk about cardiovascular disease, one of the diseases that are very, very frequent and prevalent across the population, but nevertheless underdiagnosed, is this condition called familial hypercholesterolemia. I'm sure every individual in this room would have seen a patient with familial hypercholesterolemia with high LDL levels. This is a genetic disease, and in fact, one of the most prevalent genetic diseases which are undiagnosed or underdiagnosed just because of the fact that they occur in adulthood. Individuals with familial hypercholesterolemia has almost a decade of life lost to lack of diagnosis and lack of treatment. Now, for this, of course, there's a very effective treatment available, and of course, you all do that. It is statins. But even for statins, there is a sort of precision medicine now in place. There is a dosage modification that needs to be required because of the fact that statins can cause myopathy or statin-induced myopathy. And in fact, what we show is that in a recent paper from our own lab is that approximately 10% of individuals in the population would require a dosage modification for most statins, and a third of individuals would require a dosage modification for at least one statin. Now, having said this, I will try to conclude my talk to say what is really happening today, and how is it really changing the paradigm in the years to come. And one of the things that is really happening today is genetic diagnosis is actually the end of the spectrum of a workup of an individual. So for example, an individual comes to the clinic, no normal individual comes to the clinic, as you would rightly know, and the clinician needs to make a diagnosis, and of course there is a fallout there, and the right diagnosis is confirmed using a genetic approach. In other words, a very small fraction of people are essentially benefiting from the evidence that we have at hand. Now, of course, with the cost of genomic sequencing reducing very rapidly, what we have an opportunity is to take a step back and reverse this entire thing by having an individual take the test in the first place, apparently normal individuals like you and me, and based on the evidence and actionability, you can act upon it, or the clinician can act upon it, depending upon what you have in your genome. And with decreasing cost of genome sequencing and with population scale programs, of course, you would have heard about the UK 100K programs, the All of Us program in the US, and of course, even smaller countries like Qatar and many countries in the Middle East are doing population scale genomes. That means that individuals would have their genomes available even before they step into the clinic or even before they are deceased. The second is, of course, is a convergence of genetic testing. And today we have a variety of genetic testing being offered in clinics, right from karyotyping to FISH to chromosomal microarrays to panel sequencing or Sanger sequencing. And today they look at very different kinds of genetic variations. But what we need to remember is that all these genetic variations are in your genome, and a whole genome sequencing today can offer a very comprehensive look at all of these variations much faster than any one of these tests. And with the cost dwindling very rapidly, I think this would become the mainstay, not just for genetic diagnosis, but also for screening approaches across the population. Now, when we talk about screening approaches, the obvious question is, what is the yield if you were to apply it in a general population? In fact, we have these numbers from the pilot population scale genome programs from India, and there's approximately 5%, or 1 in 20 individuals in this room, if you sequence, you're all apparently normal individuals, would have a clinically actionable genetic variant based on today's guidelines and today's evidence. And roughly speaking, 2% of them would be for cardiovascular disease, 2% of them would be for hereditary cancer syndromes, and most of them are actionable today with a very standardized methodology for early detection, early action, and of course targeted therapies. And of course, you would come to, when you talk about population scale screening, there would always be questions about what if we find a mutation which may not be in an individual who has a clinical feature. Like, for example, the titin mutations, which are very prevalent in the population. Approximately 1% of individuals do have titin truncating mutations. And very recent study from a large cohort in the US, what they've suggested is that they've essentially gone back and screened using echocardiography all people who have a titin truncating mutations. And what they show is that a significant large number of them do have subclinical heart failure. And therefore, putting these individuals on a high risk and a very regular follow-up becomes very important going forward. Now, what you need to keep in mind is that a genome is constant from the day you're born to the day you are dead. But of course, as a clinician, you can ask very different questions at different points in time. In a newborn stage, you would want to look at newborn treatable intellectual disabilities, hemoglobinopathies, very prevalent treatable genetic conditions like Wilson's disease or cystic fibrosis. But very late on, you can look at for a variety of other applications, including late onset diseases like MODY or cardiac channelopathies, or even, for that matter, hereditary cancer predisposition syndromes. I think that would necessarily mean that in the future, probably every child is going to be sequenced at birth, and we are not probably doing it yet. Many other countries are doing it to look at very prevalent, penetrant, treatable genetic disorders going forward. And of course, this year has seen one of the largest RCTs of this kind, which sort of put early newborn screening genome sequencing detection rates at around 3.7% in terms of clinical actionability, and that would mean that we have a completely new tool in our hands to help our next generation. I think to close, let me say that genome sequencing is being affordable, and that is going to be the mainstay in precision medicine. At an individual level, it can afford disease diagnosis, and at a population level of apparently normal individuals, it can provide very useful data for public health decision making. Genetic diseases are not rare, they're extremely prevalent, and therefore, genomes are not for just patients. It is probably for even apparently normal individuals like you and me. And since your genome is constant from the day you're born to the day you're dead, genomic evidence is therefore for a lifetime. Thank you very much.
Thank you for your excellent talk. You talked about pharmacodynamics, pharmacokinetics, and the drug modifications in. Being a nephrologist, I just want to add one small point before I hand over to Dr. Matthew Thomas. And for example, a 60 kilogram person with a normal creatinine of 1 milligram will have a GFR of only about 70 ml per minute. And it is necessary to modify the dose of many drugs. For example, one of the common drugs that is used now for any viral infection is oseltamivir or fluvir. And people are given 150 milligrams BD. To tell you the truth, a person with a kidney failure requires oseltamivir 1 tablet, 30 milligram, and that is to be given on every 3 days. That maintains the therapeutic level. So the dose modification of not only this antiviral drug, but many other drugs above the age of 70 years is very, very important, and I just want to highlight that point before I hand over to Dr. Matthew Thomas for the continuation.
The second topic is tumor agnostic approaches in oncology. Another coming up field, Dr. Prakash NP will deliver the lecture.
Respected teachers, Matthew Thomas sir, Kaj sir, respected elders in the fraternity, colleagues and friends, good morning. The principle of the principle of cancer treatment is the selective destruction of the cancer cells and sparing the normal cells. So we treat different malignancies. The local treatment we will do with surgery and radiation. Systemic treatment traditionally with cytotoxic chemotherapy. Again, the concept is that chemotherapy drugs will destroy the rapidly dividing cells, sparing the slowly dividing cells. That is the concept. And the tumor cells are multiplying very rapidly, and the normal cells are not multiplying at that pace. So the concept is that it will destroy the cancer cells selectively and spare the normal cells. But in reality, it is not like that. It is not sparing all the cells. Some of the normal cells are multiplying, like hematopoietic cells are multiplying very fast. So cytotoxic chemotherapy is not specific, and it has significant toxicity and has a narrow therapeutic window. So how we can optimize the treatment for different malignancies? This is what is being evaluated since long. In 15 years back, the theme of ASCO meeting was personalized medicine, personalized cancer care, or precision cancer care. So how we can offer precision cancer care? So we know that a patient with the similar histology, like say patient having lung cancer, in one person behaves differently from the other person. So why it's happening? Some of them will respond to the chemotherapy, some of them will not respond. Some of them will have toxicity, some of them will not have any toxicity. Why it is happening? It is happening because of we know that it's happening because of the heterogeneity in the biology of the tumor and heterogeneity in the biology of the patient. So how we can personalize the treatment? So we can personalize the treatment by identifying the tumor and the patient characteristics. Or the tumor characteristics, we can identify biomarkers. How can we identify biomarkers? We have to do the genetic studies as the previous speaker mentioned. So the DNA has to be sequenced. Whether the transcription is happening or not, that we have to identify by microarray. Then proteomics, metabolomics, and the immune profile of the tumor has to be characterized. So based on the identifying the tumor biomarkers, even now many targeted therapies are available, and the first one and which has revolutionized the treatment of chronic myeloid leukemia is BCR-ABL tyrosine kinase inhibitor. 25 years back, when I started learning oncology, patients with chronic myeloid leukemia, the median survival was only 3 years. But now, today, the life expectancy of chronic myeloid leukemia patient is at par with the normal individual. So this is because of we have identified an actionable mutation, and we have a targetable drug. We have a drug, and the drug is accessible to the patients. Then many other biomarkers are identified: ALK fusion targeting, EGFR, VEGF, the RAF tyrosine kinase, BRAF, BTK inhibitor, BCL2 inhibitors, and TRK inhibitors. And now we have got many monoclonal antibodies available against the biomarkers: EGFR, HER targeting, CD20 targeting, PD-L1 and PD-1 targeting, and CD20 targeting. And we have got antibody drug conjugates. So the antibody will go and bind to the specific tumor which expresses the biomarker. And the chemotherapeutic agent will work only on that cell, so the toxicity can be reduced. The gene product targeted therapy available today, that we know historically, we know that hormone receptor for breast cancer was, we all know since so many decades we are using tamoxifen is used for carcinoma breast. Then came in 2001, imatinib came to the market. Then for lung, for EGFR for lung, ALK for lung, BRAF for melanoma, BRAC1 and BRAC2 for ovary. And we have got many monoclonal antibodies: rituximab, trastuzumab, bevacizumab, then cetuximab, ofatumumab, and many other monoclonal antibodies, which are proved to have result in significant impact in the outcome of different malignancies. So how does it differ, the conventional chemotherapy from histology-dependent targeted therapy? So all this that I have mentioned was histology-dependent treatment. So if you make a diagnosis of CA breast, we will look for the markers, HER2, we will look for HER2, and if it's positive, we'll give Herceptin. So that's a histology-dependent targeted drug therapy. So the difference from the conventional cancer chemotherapy is the targeted drug therapy that will spare the normal cells and that will relatively spare the normal cells and destroy the cancer cells. Then what is tumor agnostic therapy? Tumor agnostic therapy, we have seen that for many tumors, they have different biomarkers. But same biomarkers may be expressed, may be present in different tumors. So irrespective of the histology, the biomarkers will be expressed. So this is a histology independent target specific. When we look for the target specific mutations, targeting the specific mutation, these mutations, we know that these mutations may be driver mutations, which causes the carcinogenesis and progression of the cancer. And the first drug that was approved for tumor agnostic therapy was pembrolizumab. This for microsatellite instability high or deficient MMR malignancies. So this is pembrolizumab is a monoclonal antibody that binds to PD-1. PD-1 is a receptor. PD-1 is a receptor on T cells. We know that T cells are the gatekeepers, and whenever there is one cell turns abnormal or turn malignant, so that will be identified as foreign by the T cells, and this is done by the tumor cells are identified as foreign by the T cells. So these T cells express PD-1. This PD-1, the tumor cells. Tumor cells express several tumor proteins, and that will bind on that express PD-L1, and this PD-L1 binds the PD-1 on the T cells, and the T cells are made functionless. That won't be able to. The gatekeeping function is lost. So what pembrolizumab does is it binds to PD-1 so that this interaction will not happen, so that the gatekeeping will be possible. And so this was called a successful marriage between genomics and immunology. So different tumor agnostic targets are identified in different tumors for brain cancer, head and neck, breast, hepatobiliary, GIT, genitourinary, and many. We see any tumor, different targets are identified, but the prevalence vary from malignancy to malignancy, and that ranges from 0.1% to 40%. So in tumor agnostic therapy, what is done is the tumors with a particular marker is identified, and that is considered as a group, and they are treated alike, the same drug. Instead of histology, nowadays what we do is we will treat lung cancer alike, adenocarcinoma alike, but here we group them based on the targets, and those with a particular target will be treated with the same treatment. This is tumor agnostic therapy. So there are different studies. This is regarding pembrolizumab in different types of tumors, which causes a response rate of about 30 to 35%, and about 10% of the patients achieved complete response, and they had a median duration of response of 3 to 4 years. This is regarding the NTRK inhibitors that NREC fusion protein is expressed in soft tissue sarcoma, salivary gland tumors, fibrosarcoma, thyroid cancer, glioma, and breast. And the different studies have shown that the overall response is about more than 70% with a CR rate of about 16% and median overall survival of about 44 months. Then BRAF mutation in metastatic melanoma that also has shown significant response rate as well as progression-free survival and overall survival. Then BRAF is mutated in biliary tumor, anaplastic thyroid cancer, many other malignancies. So in tumor agnostic therapy, how it is different from histology-dependent target therapy or conventional therapy. In tumor agnostic therapy, we are not looking at the histology, we are looking at the marker expressor and treating it based on that.
Prakash, please conclude.
So the drugs that are approved by FDA for tumor agnostic therapy are NREC inhibitors, that is ladatinib or entrectinib, then PD1 and PD1 targeted therapy by pembrolizumab and dostarlimab and then trastuzumab. And what is done when we do a clinical trial, what we do is we look for a specific disease, and this specific disease we give a specific treatment. But for tumor agnostic therapy, what we do is we take different types of tumor with the same marker, and they are treated alike. So the advantages are we get a more effective treatment, and we will be able to treat rare diseases, and there will be an early drug approval.
Please conclude, Prakash.
Thank you.
Thank you, Dr. Prakash, for that wonderful information for us. Oncology is going very high in precision treatment, and he has given so many examples. Thank you so much. And we'll go to the last topic, targeted therapy in pediatric rare disease by Dr. Shankar.
Okay, good morning to all. At the outset, I thank the scientific committee headed by Vinay Kumar sir, Suma madam for giving me the opportunity in my own alma mater where I have studied from 1986 to address a big audience of most of the people are my teachers. So I cannot start from my chairs like Kashi sir, Matthew Thomas sir, Mahadevan sir, and so many other teachers. I'm seeing Vijay Lakshmi madam is there. So many of my teachers are there. So coming to the topic, targeted therapy in pediatric rare disease. Greetings from Thiruvananthapuram, okay. So actually my first speaker, Vinod, has told about the monogenic disorders and common diseases. So I am basically dealing for last 20 years with the monogenic disorders, rare pediatric diseases, where it is a single gene disorders, where what are the options of therapy, which I am going to tell in next 10 minutes. So levels of therapy in genetic disorders. So 80 to 90% of rare diseases are genetic disorders. So how the treatment has changed in last 20 to 25 years. So as you know, the genetic therapy is very easy, very simple. Mathematically, it is very easy because there is a mutation in a gene which is causing an abnormal mRNA, which is causing an abnormal protein. That protein will cause an abnormal pathology in the organ, which will produce the clinical symptoms, which will produce a lot of family issues. So we have to start from the mutant gene, where there can be a gene therapy or a transplantation which will actually correct the gene itself. Or it may be a mutant mRNA, where a small interfacing RNA like RNA-based therapy like primary hyperoxaluria, where we are using lumazarine. Or a mutant protein, where we are using enzyme replacement therapy in lysosomal storage disorders. Or metabolic dysfunction, where there is an abnormality in the organ, where there is a dietary therapy or a pharmacological therapy will correct that metabolic problem. Or still down the line, where there is abnormal symptoms, where we will do the symptomatic therapy, or abnormal birth defect, we will do some surgical correction for the birth defects. Still below that, family, we can do the genetic counseling, prenatal diagnosis, prevention in the next baby. So generally, genetic disorders has a bad thing, that is, it is not treatable. But 100% of genetic disorders are treatable in one of the three. That 3C concept is cure, control, and care. Almost all diseases we can care. Even if we cannot cure the disease, we can care the family, we can prevent the genetic counseling, we can help the family. So many things can be done. So 100% of genetic disorders are treatable. Some are controllable by various means. Some are cured by newer therapies. So coming to only three scenarios which I'm going to discuss today, because it's a huge topic, I may not be able to do in 10 minutes. So enzyme replacement therapy, which we are doing it recently. This is concept given by Dewey by the introduction of he identified that the lysosomes having more than 46 enzymes, which has actually formed in the endoplasmic reticulum. And from the endoplasmic reticulum, the protein is transported to the lysosome by the mannose-6-phosphate receptor capture-mediated pathway. So if you give intravenous some injections, that injections can go into the lysosome and the storage disorders can be corrected. After that, enzyme replacement therapy first in 1991 came for the Gaucher disease. Now it's the standard of care of management. Then Fabry's disease, MPS type 1, type 6, Pombe's disease, MPS type 3, etc. And Niemann-Pick, galactosialidosis, Woolman's disease. A lot of enzyme replacement therapy has come into the picture. And this is some of our patients where we are giving enzyme replacement, especially in Gaucher disease, where it has an excellent response. And it is a standard of care of management. Hemoglobin at 3, 4, they are getting recurrent transfusion. Now hemoglobin is 10, 11. Spleen has reduced, liver has reduced, their lung symptoms has reduced. So it is a standard of care of management for the Gaucher disease. And we are also having an IAP guidelines on how to manage. So that shows that in Indian pediatrics, it's a pediatric forum. There also we are having a entire guideline on Gaucher disease management, which shows that it should be the standard of care of management of any patient with Gaucher disease. With the help of Center of Excellence, and we were able to manage all our Gaucher disease patients on enzyme replacement therapy, and they are having excellent response. It is other scenario where it's called a Pompe disease. It's a 2-month-old presented with a cough and breathing difficulty, and left tissue transaminites, hepatomegaly, cardiomyopathy, hypotonia. You can see the huge heart. So it's a Pompe disease, and most of these patients are dying by around 6 months to 1 year, or they are having a significant muscle problems and they are not able to walk. This patient, we have started the enzyme replacement therapy at the age of 4 months of age, and you can see that how the transaminitis has come down, how the ejection fraction and the cardiac mass has come down, and how the patient has responded, and he is significantly had a hypotonia, and by around 9 months, 10 months, he is moving his upper limb, lower leg, everything. He is playing with the child. Parents are very, very happy. Every month he will give one video to me saying that he is moving his leg, So definitely there is improvement with the Pompe's disease, but they can have some problem also. Later he developed a severe bad pneumonia and put on ventilator, and now he is having tracheostomy, but he is having a significant other motor functions and cognitive functions improved. Now coming to gene therapy has various forms of gene therapy like gene augmentation therapy. That means we are giving the gene itself by putting into the adeno-associated vector most probably, but in hemophilia it is lentivirus. Depending upon the condition it will be different. So adeno-associated virus is the most commonly used, and gene augmentation therapy is still little bit far away because it is very much expensive. We were not able to routinely give. But other gene therapy molecules like antisense oligonucleotide, like conventional ASO, small molecules like risdiplam, which can be given for spinal muscular atrophy, which will actually helping the SMN2 gene expression to increase, or read-through stop codon like PTC that is used in the various conditions. RNA interference, already I told, the lumasiran in primary hyperoxaluria, and gene editing molecules are coming for the sickle cell anemia. I will give 1 or 2 examples of that. So there is a success stories of gene therapy. Even when I am doing my DM in 2004 to 2007 in SGPGI, I used to present during my symposium. Even the DM genetics group, we will feel that it may be a hope only. But in last 17 years, now I have able to treat a patient on gene therapy. That is very rewarding and successful. So you can see that spinal muscular atrophy, so many molecules are there. I will give 2-3 slides on that. Then Duchenne muscular dystrophy, new options are coming. Mahadevan sir is Leber's congenital amaurosis, RPE65, AAV2 vector Luxtrana is already Novartis is marketed. It's a 4 crore is there. And so many higher centers like Shankar Nethralaya and Aravind, they are using this molecule for treat congenital amaurosis. Thalassemia gene therapy is coming in a big way. Hemophilia B already a group from Emory plus CMC Vellore, Alok Srivastava and group. They have identified a gene. It's a phase 3, phase 4 study. Matthew Thomas sir knows that immediately it is going to market that probably in hemophilia B. Hemophilia A, it's a little bit bigger gene, so it's very difficult to put gene therapy, but some improvements are coming. Achondroplasia vosoritide, which is a gene therapy like molecule, but it is not actual gene therapy. Cystic fibrosis, modifiers like ivacaftor, all things are available. Immunodeficiency disorders, neurofibromatosis, malignancy, infectious disease, cardiomyopathy. So most of these conditions, next 10 years, it is the era of gene therapy molecules. So gene replacement therapy for SMA came in a big way. As you know, 16 crores, so many social media, WhatsApp groups and other things. But it is having not an excellent response, but some responses are definitely it is increasing the event-free survival. Spinraza is another antisense oligonucleotide which has given for around 16 to 18 patients in Kerala, various charitable access program, but we have not taken in a bigger way. But it has given in a charitable access program in trials in nusinersen. Some children are getting. It is also a reasonable benefit. But this risdiplam, it is an oral drug, which is a pharmacological drug which will increase the expression of the SMN2 gene, thereby preventing or improving the symptoms of the patients. So government has also taken up this initiative, and we are giving for around 100 patients, we are giving the risdiplam. And type 1 patients, most of the patients have prevent the death. That is survival benefit is there, and they are having some improvement. That means non-sitters are becoming sitters, sitters are becoming walkers. So some improvement is there, but I cannot say it's a 100% improvement like Gaucher disease. So there are 3 molecules for SMA, nusinersen, zolgensma and risdiplam. So we are having a larger group of patients we are treated with SMA through SMA clinic. DMD is also a lot of experimental therapies are coming, like AAV-mediated mini-dystrophin, because dystrophin gene is one of the largest gene with 79 exons. So it's very difficult to put into a small viral vector. So they have identified some specific area, and that is called mini-dystrophin gene, which is put into the AAV vector and having some benefit, but it is not total benefit. That is why not like SMA, it came in a bigger way. Then exon skipping therapy, which is specific for some diseases. Then stop codon read through PTC and CRISPR-Cas, which I will take 1 minute for that, because this is the much more newer thing, CRISPR-Cas. Because here it is not a AAV vector. The CRISPR-Cas will go inside the body or inside has come for the sickle cell anemia, because sickle cell anemia is a point mutation, 100% patients having same mutation. So this is the drug of choice. Probably it is going to come in India, because some Indian ICMR studies are also going on for this. In epilepsy also, because previously we used the symptomatic therapy, now it is mainly the targeted therapy for epilepsy. And another condition is plexiform neurofibroma, because plexiform neurofibroma, neurosurgeons know sometimes it may be untreatable. This is one patient from Bangalore, from our neurosurgery colleagues from Srijitra also felt it is non-treatable because it's a very huge plexiform neurofibroma with MRI, where we have started with a selmitinib, which is a treatment of choice for plexiform neurofibroma, and we have started this patient for last 1 year, and after this the patient can walk, patient can run, and patient is doing some playing also. So actually the selmitinib is also doing an excellent improvement in the neurofibromatosis. Primary hyperoxaluria, already I told RNA interface therapy with the lumasiran, because we are having so many patients with primary hyperoxaluria where we are doing preemptive liver transplant or a liver kidney transplant. So the lumasiran will change the entire scenario where everything can be prevented. So all these things having a very prohibitive cost is there. With the help of the Center of Excellence, we are also one of the Center of Excellence, one of the 12 Center of Excellence in India by ministry. So they are having a lot of funding mechanism for helping these patients. That is why we were able to give for these beneficiaries. Our beneficiaries somewhere around 30, 40 now. And we are continuously doing it because it's a continuous process. Because we are having a comprehensive genetic services. As I rightly told, genetic counseling, prenatal diagnosis, everything also will be a part of it, which I have not covered in this small talk of 10 to 15 minutes. So take home message, there are various targeted therapies are available. Enzyme replacement therapy, Pompe disease and Hunter syndrome, Gaucher disease, etc., gene therapy, different options, spinal muscular atrophy, Duchenne muscular dystrophy, precision medicine in epilepsy, selmitinib, but genetic counseling, don't forget carrier screening and prenatal diagnosis. Acknowledgement to the entire, my seniors, DME, principal, superintendent, all have written left. Right is my entire lab team, or 10 to 12 people are there. Without that, I may not be able to do this or told to you, because it's an entire team of SAT and Medical College Trivandrum. We were able to do that. Thanks to DME also. Thank you, sir.
Thank you, Dr. Shankar, for the nice talk and a lot of